Hello, my name is Bill Krebs. I'm an ER, EMS, and critical care transport physician. I have a little gripe with MRAP on their current bias on Rocuronium versus succinylcholine. I'm a long-time listener, first-time caller. MRAP provides an outstanding education and an interesting variety of perspectives that in the right setting can help improve patient care and practice. The P, though, stands for perspectives, and unfortunately I feel that there has been a bit of a biased presentation in the MRAP presentations on ROC versus succinylcholine. Your team of experts is obviously exceptional and clearly much smarter than I. However, what I am seeing in the community practice leads me to question the experts' recommendation outside of their specific institutions. This topic hits close to home for me, and that in the small program I work with, not one but two providers experienced the dreaded, paralyzed, and awake situation when given Rocuronium. Now one is actually unable to work and is permanently disabled due to PTSD. Working as a critical care transport provider and seeing the care provided to the patients and how it's changed over the last 10 years with respect to paralytic choice, I'll argue that Rocuronium should actually have contraindications, and there are times when Sux is going to be the better choice. You may ask, why would I speak such heresy against Rocuronium? Well, there's literature out there that's covered as well on your sister program, EMA. ROC is no better than succinylcholine and may actually be worse in some meta-analyses. Now, I'm not going to go into this debate. This is covered completely well on your sister program. But what we do know and what is clear is Sux is not worse in any way than Rocuronium for first-pass intubation success. Additionally, there are patients where long-acting paralytics like Rocuronium are going to be dangerous to the patient and should be avoided if contraindications to succinylcholine do not exist. Seizures were a perfect example mentioned by Scott Weingart in the October MRAP edition of this year, in which he noted that succinylcholine would be preferred if he did not have access to Sugamidex. Even those who pretend that Rocuronium should be the ideal and perfect medication note that in the case of seizures, Sux would probably be preferred. Additionally, cases like strokes, intracranial bleeds, and subarachnoid hemorrhages, where seizures can occur, additionally, good neuroexams are important, and having a better understanding of how to safely manage an intracranial pressure on these patients also are reasons that succinylcholine is the better choice over Rocuronium in these cases, if not contraindicated. One can argue that succinylcholine is actually the preferred medication when it comes to avoiding patient suffering compared to Rocuronium. There are studies that have been discussed, specifically the ED awareness study discussed in your sister program EMA, that suggests that a higher percentage of patients are awake and paralyzed with Rocuronium as compared to succinylcholine. This is backed up by smaller studies that suggest that patients who receive Rocuronium have a delayed time to pain and sedation medication and dosing. To counter the point that all that is needed for safe Rocuronium use is aggressive pain and sedation protocols and pathways, unfortunately does not take into account the current healthcare crisis, nor does it address the problems faced by most community hospitals with extremely high volumes and inadequate or overworked staff. It'd be wonderful if these ICU level patients had a 1-to-1 or 1-to-2 nurse to patient ratio. Unfortunately, most of the nurses and staff are often pulled away from these patients to see other potentially critical patients with strokes, STEMIs, or other time-critical illnesses. To the point where it would actually be nice to have an even 1-to-4 nursing ratio for a patient in these cases, because most hospitals are so overwhelmed. Additionally, unfamiliarity with medications is a known risk for errors and problems. And with the extremely high staff turnover, to the tune of nearly 1/3 of the staff turning over in a year, makes it so that most providers lack familiarity with these medications and pain and sedation pathways. So much so that you can ask any critical care provider, and most will tell you of a story of a patient whose GCS was 3 or RAS was -5, and the staff did not give pain or sedation medication to a paralyzed patient. Lastly, Sugammadex, which is mentioned as a nail in the coffin to succinylcholine, is not a perfect solution. We are taught in medical education to consider costs and cost-effective care. At least in our institution, this is an extremely expensive medication that could support a nurse or a tech or an additional provider for a 12 or 24-hour shift if it was used. That seems a lot better to actually use the provider and use succinylcholine to me. Unfortunately, this high cost makes it unavailable in the majority of ER settings and is only stocked in neurosurgical cases in the OR. If we're in a situation as well where we have had to give Sugammadex, we now limit our choices of paralytic and ability to use a paralytic should the patient be unable to ventilate, such as a COPD or asthma patient. In summary, be a switch hitter. Know how to use both medication. Understand your situation and what medication works best for the patient, not what is easiest. We have a multitude of medication at our fingertips. And please, MRAP, avoid the blanket statement that ROC is the best choice or better choice until there is clear evidence in the literature.